In this next section entitled Antivirals, we'll talk about these medications as well as specific viral illnesses in which they should be given. In this section, we'll discuss antiviral therapy. There are multiple classifications of antiviral medications. Many antivirals are antimetabolites that are related to DNA bases that require metabolic activation and can block viral growth that way. Other antivirals can target proteins that are unique to virus, such as the HIV protease and the neuraminidase seen in the influenza virus. For antiviral chemotherapy, there are multiple different sites of action that can be used to kill the virus. For uncoating the medications, amantadine and rimantadine are commonly used. Some antimetabolites, such as acyclovir, ganciclovir, and vidarabine, are used to block nucleic acid synthesis. Interferon is actually used to block protein synthesis directed by viral mRNA. And protease inhibitors are used to block the proteases that are responsible for maturation of virus proteins. Let's talk about the herpes viruses. These are some of the most common viral infections in humans, and the therapy that we have for herpes virus is usually pretty straightforward. Herpes zoster is a common infection, also known as shingles, that involves the varicella zoster virus. Not the herpes simplex virus, but this is actually the chickenpox virus. It's reactivated in a dermatome, and this patient has developed herpes zoster in the distribution of the ophthalmic branch of the trigeminal nerve. This is a patient with classic shingles that has developed reactivation of the zoster virus upon two different dermatomes at the same time. Herpes viruses, as you know, cause a positive tank smear showing a multinucleated giant cell in the infection from a surface scraping. There are certain medications that we can use against herpes viruses. These medications are either antimetabolites or inhibitors of DNA polymerase, and they include acyclovir, valacyclovir, which are basically the same medication. Valacyclovir is considered a prodrug of acyclovir, ganciclovir, and foscarnet. Acyclovir is an antimetabolite that interferes with DNA polymerase and acts as a chain terminator. Valacyclovir is a prodrug. Valacyclovir gives you approximately 10 times higher blood levels as acyclovir. Acyclovir has good activity against herpes simplex virus and varicella zoster virus, poor activity against cytomegalovirus. Acyclovir has lots of clinical applications. We use it very often in the hospital. Patients that have genital herpes will often go on valacyclovir to prevent passing along of their herpes infection. This medication is often used in immunocompromised patients that have varicella zoster exposure or infection. Acyclovir does have adverse effects. Patients that are receiving IV acyclovir can develop crystalluria. So it's very important these patients receive lots of hydration in order to prevent crystals from forming in the urine and kidney damage. Acyclovir can also cause neurological side effects, including delirium, tremor, seizures, and hypotension. Ganciclovir is very similar in structure to acyclovir, but has very good activity against CMV, or cytomegalovirus, which is a different type of herpes virus. Prophylaxis of CMV infections, as well as treatment, is carried out by ganciclovir, especially in immunocompromised patients. Ganciclovir does have an adverse effect of bone marrow toxicity and can cause the same side effects as acyclovir. Foscarnet is an alternative to ganciclovir that directly inhibits the DNA polymerase and the HIV reverse transcriptase. It is considered second-line agent for CMV infections. Foscarnet is a very difficult drug to take and causes very severe nephrotoxicity and lots of central nervous system symptoms. Therefore, we only use it when a patient cannot take ganciclovir. Let's talk about HIV treatment, and we'll talk about the different antiviral targets in the treatment of human immunodeficiency virus. The reverse transcriptase is a very common target that two different drug classifications are used to attack. There are the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. The HIV protease is also targeted in medications that are protease inhibitors, and then a newer classification of medications are the entry and fusion inhibitors that are used against HIV. The NRTIs, or nucleoside reverse transcriptase inhibitors, are antimetabolites that are nucleosides that are able to prevent acute infection of cells, but they do not affect cells that are already infected. The prototype medication was AZT, or zidovudine. The NRTIs are very helpful in treating HIV infections, and there are many different medications that are available clinically. The NRTIs are components of a lot of different drug regimens. HAART, which stands for highly active antiretroviral therapy, will usually contain 3 HIV drugs from at least 2 different classes, and most of these HAART therapy regimens will contain at least 1 NRTI. NRTI resistance does occur, usually because of mutations of the reverse transcriptase gene, and then once that reverse transcriptase gene has mutated, there will be resistance between multiple different NRTIs at the same time. NRTIs are ineffective over long term as the sole agent because of resistance of the virus, and HIV has a very high mutation rate. Therefore, NRTIs must be given along with other medications to be effective. Some adverse effects of NRTIs are classic and might be tested on the boards. Most of these NRTI agents can cause peripheral neuropathy, so it's important to remember that. AZT, however, is known to cause hematotoxicity, and DDI is known to cause pancreatitis. Another class of medications, the NNRTIs, or the non-nucleoside reverse transcriptase inhibitors, work by directly inhibiting the active site of reverse transcriptase. And they include the medications nevirapine, efavirenz, and dolaverdine. Some adverse effects of the NNRTIs include multiple interactions between other medications because they can be either inducers or inhibitors of cytochrome P450s. It's not important to remember which of these are which. Other adverse effects include rash and CNS toxicity. Most likely you will not have to remember the exact adverse effects from different NNRTIs. Just be able to recognize the nucleoside reverse transcriptase inhibitors versus the non-nucleoside reverse transcriptase inhibitors for the step 1 of the boards. Protease inhibitors are also very effective. These usually end in AVIR, so they can be identified that way. Sequinavir, indinavir, ritonavir, and melphinavir. The way they work is by inhibiting the protease. This protease is responsible actually for assembly of viral proteins and maturation of those proteins into their mature form. Mutations in the POL gene in the HIV virus will confer resistance to protease inhibitors. There are classic side effects that are seen in protease inhibitors. The most classic one is lipodystrophy, and this is occurring in patients that are taking protease inhibitors for a long period of time. These patients develop insulin resistance and unusual fat redistributions. These protease inhibitors can also inhibit cytochrome P450s and cause drug-drug interactions. Here are some photographs of a patient that has developed lipodystrophy from protease inhibitors, and as you can see, they've developed buffalo hump obesity, as well as truncal obesity, and abnormal fat distribution in the face. And you can see that this patient as well has developed buffalo hump obesity because of protease inhibitors. With regard to entry and fusion inhibitors for the treatment of HIV, there are many agents in clinical trials, but there is only one drug so far that's been approved, and that's enfuratide, or Fusion, which binds to GP41 on the surface of HIV and is often used in refractory HIV infection. Just to recap about HAART therapy, which stands for highly active antiretroviral therapy, this is usually a triple therapy regimen with AZT, DDC or lamutavine, and sequinavir. It's important to vary these HAART regimens based on what the sensitivities are of that person's virus. The virus is usually grown out in culture, and it is tested to see whether it's resistant to these medications or not. There are usually 2 nucleoside or non-nucleoside RT inhibitors along with a protease inhibitor. Pediatric heart regimens usually do not include protease inhibitors because you want to avoid lipodystrophy in children. Let's talk about some other antiviral agents, including amantadine, oseltamivir, and ribavirin. Oseltamivir and zanamivir are neuraminidase inhibitors and work on influenza A and influenza B. These medications are very effective and they can prophylax against infection. They also may shorten the duration of symptoms in active influenza infection. Oseltamivir, also known as Tamiflu, is also currently being stockpiled by the U.S. government in anticipation of a flu pandemic across the world. These are known to cause GI distress and can also cause bronchospasm. Ribavirin is another antiviral medication that inhibits a wide range of viral infections. The way that it works is by interfering with the RNA-dependent RNA synthesis in multiple viral infections, but the exact method is unknown. It's used for multiple different viruses, including RSV, hepatitis C, and the hantavirus. Toxic effects of ribavirin include bone marrow toxicity and anemia. It is also a teratogen and should be avoided by pregnant women. Interferons are a newer category of antiviral medications. These proteins are actually native proteins to the human, and usually they're secreted by a virus-infected cells. Alpha and beta interferons are generally released in response to a viral infection. What they do is they provide immediate protective host responses. They enhance the expression of class 1 and class 2 MHC molecules, which are antiviral molecules, and then they enhance presentation of viral antigens on the surface of the viral infected cell so that the body can see which virus is attacking it. And then alpha and beta interferons also activate cell surface receptors and activate JAK-STAT pathways to increase an RNase expression in the cells. Gamma interferons are also cytokines that are secreted by helper T cells that enhance specific T cell immune responses. All of these can be given as a recombinant protein to patients that have viral infections. Interferons classically are very unpleasant drugs to take. They can cause fevers and chills and malaise. They can actually cause depression as well. They can also cause liver toxicity, and because of bone marrow problems, can cause leukopenia. Interferon alpha is used in chronic hepatitis B and C infections, can be used in genital warts, hairy cell leukemia, and Kaposi sarcoma. Interferon beta is used in refractory multiple sclerosis, and interferon gamma can be used in chronic granulomatous disease. This concludes our section about antivirals. Next, we'll move on to other medications given commonly for patients that have parasitic infections and malaria.